So here's the narration for chapter 31 on neurological emergencies. According to the Health and Stroke Foundation of Canada, cardiovascular disease, which includes heart disease and stroke, is the leading cause of death among Canadians, 29% of deaths. Clearly, you will encounter many neurological diseases. Patients with acute neurological emergencies or chronic neurological disabilities can be extremely vulnerable or even helpless. Many of the reflexes that protect an awake person may be temporarily or permanently impaired when the nervous system is compromised. The eyelids do not blink away dust and irritants. The larynx does not gag and cough in reaction to secretions oozing down the airway. The body does not seek a more comfortable position in response to compression of a limb in an awkward position. The tongue goes slack. The airway is at risk. Certain risk factors for cardiovascular disease is age, gender, genetic predisposition, previous medical conditions, and a history of trauma. So for this section, we'll cover the anatomy and physiology of the nervous system. We'll start with that first, and then we'll go over the general pathology of neurologic conditions. Again, this is a little bit outside of this scope, but since we're on the topic, we'll go into some of the most common neurological conditions that you may be faced with, just so that we can create at least a foundation for discussion in terms of assessing those conditions. So let's start with a scenario. You're dispatched for an older man who has fallen. You find an 81-year-old man lying on the floor. His two sons explain that they visited their father last night and left around 1900 hours. When they returned this morning, they found their father lying on the floor next to the chair in which he was sitting when they last saw him. He has been unable to explain what happened. They describe him as usually very sharp, but today he keeps getting their names confused. They say this only happens when his blood glucose is low. The patient has a history of type 2 diabetes. So why do you suspect that the patient is on the floor? And how would you prioritize those reasons? So starting with the anatomy, the nervous system is the most complex organ system within the human body. It consists of two major structures, the brain and spinal cord, plus thousands of nerves allowing every part of the body to communicate. This system is responsible for fundamental functions such as controlling breathing, heart rate, and blood pressure. But the real beauty of the nervous system is found in its higher level activity. Reading a good book, enjoying music, having a discussion with a friend, and even watching television require the brain to engage memory, understanding, and thought. Here's where the true complexity of this system can be seen. So looking at the major structures, they're divided in two main categories. We have the central nervous system, which is responsible for thought, perception, feeling, and autonomic body functioning. And then we have the peripheral nervous system, or the PNS, which transmits commands from the brain to the body and receives feedback from the body. Consider the case of little Justin, a child riding a bicycle. This common and seemingly simple activity is rich with both conscious and unconscious functions. It is a beautiful summer morning, so Justin goes to the garage to get his bike. Already the brain is hard at work. As Justin enters the garage, the brain must determine which object is a bike. Justin scans the garage. The images produced by his eyes are transmitted via the optic nerve to the occipital lobe of the brain, which is at the back of the brain. There, the image which is transmitted upside down is reoriented. The occipital lobe then pours through the tens of thousands of stored images. Occipital, again, being at the rear. And it's thinking, has this image been seen before? Once the image is recognized, an existing pathway is accessed to the temporal lobe, which is on the side of the brain, where language and speech are stored. Now, as Justin walks through the garage, he's able to put names to what he sees: a car, a workbench, a bike. When Justin was learning to speak, he often became confused about the names of objects. As he practiced, he received reinforcement for the correct names and redirection of the incorrect names. In his brain, more pathways were established between the image of an object with two wheels, a seat, and pedals, which was stored in the occipital lobe, and the word for that object, bike, which was stored in the temporal lobe. As Justin retrieves his helmet, the frontal lobe of his brain springs into action. The frontal lobe, which controls voluntary motion, sends signals out to the CNS, central nervous system, along with efferent nerves to the arms, shoulders, chest, and hands to perform the task of picking up the helmet. The efferent nerves leave the brain through the peripheral nervous system and convey commands to other parts of the body. Which way should the helmet be applied? This motor memory is stored in the frontal lobe. The brain stores memories in the areas that are initially stimulated. As he places the helmet on his head, Justin needs to make fine adjustments to his position. His brain is receiving impulses from nerves within the skull and muscles of his head, indicating that the helmet is uncomfortable. Justin senses pressure and possibly pain from the improperly positioned helmet. The afferent nerves that send information to the brain transmit signals of discomfort to the parietal lobe, where the body's sense of touch and pain perception are found. Signals sent from the parietal lobe to the frontal lobe make the body adjust the helmet until the pressure signals have stopped. As you've been listening to this tale, huge amounts of information have been pouring from your peripheral nervous system into your central nervous system. Signals are sent from organs, muscles, and areas of the skin to the spinal cord until they reach the lower portions of the CNS. The position of your legs, the distribution of your body weight, the sensation of even just listening to this, the state of your renal arteries, all this data are being sent to the CNS. So how does the brain manage this massive amount of information without confusion and misdirection? By using the diencephalon and the brainstem. One of the major roles of the diencephalon is to filter out unneeded information from the cerebral cortex. Imagine if you had to think about shifting your weight on a chair when it became uncomfortable. The signals of pressure or pain being sent via the peripheral nerves initially stop in the diencephalon. The body's administrative assistant then decides whether the big boss, the cerebral cortex, needs to be bothered with this information. In the case of an uncomfortable bottom, the diencephalon simply sends commands so that you move slightly. Unless you were concentrating on how you were sitting, you would never have even known that you moved. How did Justin know it was time to get up this morning? His internal alarm clock went off, of course. The midbrain, part of the brainstem, is responsible for regulating the level of consciousness. You often get tired at the same time each day due to the functions of the reticular activating system, or the RAS system. Justin is wide awake and thinking clearly thanks to his RAS. How are blood pressure, heart rate, respiratory, and breathing patterns controlled? Again, the brainstem is responsible. The pons, which is located just inferior to the midbrain, regulates your respiratory pace and depth at which you breathe. The medulla oblongata controls the blood pressure and heart rate. Of course, these functions need to occur constantly, but Justin could not ride his bike if he needed to spend time and energy consciously controlling his pulse. The brainstem frees the cerebral cortex up to engage in higher level activities. Justin now mounts his bike and begins to ride. The smile on his face reveals that he's having fun. Emotions come from two main areas within the brain: the limbic system, where rage and anger are generated, and the hypothalamus, which is a part of the diencephalon, where pleasure, thirst, and hunger are found. All motions are then mediated by the prefrontal cortex, so people can choose how they are going to act in relation to how they feel. Justin begins to pick up speed, and as he approaches a corner, he must turn or risk crashing into a tree. The excitement increases his heart rate and blood pressure. The hypothalamus communicates to the pituitary gland, a member of the endocrine system. The pituitary gland in turn sends chemical commands to the adrenal glands to release epinephrine and norepinephrine. These are the glands that sit on top of your kidneys. The release of these chemicals by the sympathetic nervous system gives Justin the increased strength and cardiovascular reserves that he needs to handle the bike in a right turn, or in a right tight turn. Just as quickly as these chemicals act, they are shut off to prevent the body from depleting its reserves. Too much epinephrine and norepinephrine can also be damaging over the long term. Justin shifts his weight and makes the turn successfully, due in large part to cerebellum. This lobe of the brain, located posterior inferior area of the skull, manages complex motor activity. When Justin first learned to ride a bike, he had to think about what to do, where to shift his weight, and how to hold up his upper body. Eventually, the frontal lobe of the brain got tired of sending the same command again and again, so this task was transferred to the cerebellum. This lobe keeps track of Justin's body position at all times and helps to manage activities such as walking, swimming, and riding a bike. All of this wonderfully complex activity is made possible by the synapses that we see here. Nerve cells do not actually come in direct contact with one another. Instead, a slight gap separates the cells, which allows for a far greater level of fine control. The synapse, which is present wherever a cell nerve terminates, connects to the next cell via chemicals called neurotransmitters. A host of neurotransmitters are present in the brain and throughout the body. Dopamine, acetylcholine, epinephrine, and serotonin are all examples of neurotransmitters. These chemicals take the electrically conducted signal from one nerve cell, a neuron, and relay it to the next cell. Nerve cells respond to these signals in an all-or-nothing fashion. They either fire or they do not. A neuron cannot fire weakly. So how do the neurotransmitters achieve a greater degree of control than that permitted by simply wiring the cells together? The answer lies in the connections made as the signal travels from the cell to the synapse. First, the first neuron fires and sends a signal along its axon to the axon terminal. Next, the impulse reaches the axon terminal, where neurotransmitters are released and trickle across the synapse. Then dendrites detect these chemicals and are triggered to send the signal to the cell's nucleus, which then transmits it down that axon and so on. Dendrites release neurotransmitter deactivators so that one impulse from cell 1 generates one response from cell 2. The complexity in the system derives from how the cells are connected. Each cell is connected in a straight line fashion. Although this is a reliable method of getting a signal from point A to point B, gaining more control requires more complexity. So 3 cells are brought together to connect with the same cell. Cell 4 will not respond unless it receives simultaneous stimulation from cells 1, 2, and 3. The same concept can be extended to a situation in which one cell sends signals to many different cells. For example, if cell 4 stimulates cell 5 and 6, as a consequence of this joint action, Justin is able to see his bike, recognize the object, know its name, instantly know how to use it, know how to make the muscles of his mouth say the word bike, and appreciate how it will feel to ride the bike. Neurons may or may not have myelin around their axons. Myelin, a protein wrapped around the nerve cell, acts as an insulator. It helps prevent the electrical signal from leaving the nerve cell and entering the surrounding tissues, but its major function is to increase the speed of conduction. Myelinated nerve fibers are predominantly found in vertebrates and higher organisms, all of which rely on rapid nerve conductions to allow higher thought and brain functions. Moving on to pathophysiology. The pathophysiology of the nervous system can be examined from several angles. Discussion of cancerous, degenerative, developmental, infectious, vascular, and multifactorial causes of neurologic conditions will be followed by a review of increased intracranial pressure, or ICP, and its effect on the nervous system. Let's look at our case again. The patient is alert and oriented to person and place, but is unsure as to what day it is and cannot describe the events leading up to your arrival. The patient shows no signs of trauma. During your assessment of his pupils, however, he takes your pen light and tries to shave his face with it. He seems to use inappropriate words for common objects and appears frustrated that you can't understand it. So given this information that you have now, what do you think could be the patient's underlying illness, injury, or condition? Do your assessment and treatment priorities ever change? And what are appropriate interventions for this patient? So looking at your patient assessment, so in general, as your general assessment, the brain is the organ that is most sensitive to fluctuating levels of oxygen, glucose, and temperature. It responds to alterations in these levels with changes in its functions. The difficulty is that the brain is relatively resilient to internal environmental changes. It does not simply shut down when oxygen levels fall. The key to identifying a neurologic problem is to look for both the gross or obvious changes and the subtle, sometimes hidden changes that can indicate disease. So let's keep going a little bit further. Looking at your scene assessment. Of course, personal protective equipment, your PPE, and routine precautions are taken for granted in anywhere you work. Their purpose is to protect you from exposure to potential harmful organisms or environments. Patients having tonic-clonic seizures, for example, may be incontinent. Some unresponsive patients may be experiencing overdoses. With the use of illegal drugs, the presence of weapons, money, and crime increases. This potentially places you close to armed criminals. Patients with altered level of consciousness may not be able to walk, may be combative, or may be completely unresponsive. You may need additional assistance with lifting and moving these patients. Special circumstances can be overcome easier if additional resources, such as, for example, in some systems, helicopter transportation or rescue equipment from firefighting or fire suppression, are requested early in the call. So examine the scene to ascertain the number of patients. Clues can be obtained from dispatch information, of course. Also consider the mechanism of injury or history of present illness. Motor vehicle collisions typically involve more than one vehicle and therefore more than one patient. If many patients exhibit similar signs and symptoms, you should be very cautious. One patient with a headache does not stand out. If an entire family in the same house reports a headache, then you should consider the possibility of carbon monoxide exposure. In some cases, or in such a case, the house may be an unsafe scene, so ensure that you have the correct personal protective equipment. Weapons of mass destruction can follow similar patterns. If you encounter several patients who all exhibit the same signs and symptoms, all within the same general time frame and geographic location, you should consider immediate evacuation and don appropriate PPE and contact the dispatcher to begin a more in-depth investigation. Moving on to your initial assessment. Begin the neurologic assessment as you would with any other patient. Assess and secure the ABCs. Use the AVPU system to determine the level of consciousness. If the patient does not respond to verbal stimuli, consider whether he or she is maybe displaying some abnormal posturing. These unconscious movements may indicate severe brain dysfunction. There are two main abnormal postures that the patient may demonstrate with painful stimulation. So we call that decorticate, okay, so coming towards the body, and decerebrate, going away from the body. If you see either posture, you should immediately consider the patient to be critical. So going a little bit more detail, so decorticate posturing, also called abnormal flexion. The patient flexes the arms and curls them towards the chest or towards the core of the patient. At the same time, they point their toes. Finally, the wrists are flexed. This posture may indicate damage to the area directly below the cerebral hemispheres. In decerebrate posturing, also called abnormal extension, the patient points the toes, but now extends the arms outward and rotates the lower arms in a palms down manner, called pronation. The wrists are again flexed. This posture is a more severe finding than decorticate posturing, as the level of damage is within or near the brainstem, the brainstem being the diencephalon, pons, and the midbrain that we just discussed before. Moving on to the airway. So the trigeminal, glossopharyngeal, vagus, and hypoglossal nerves are responsible for airway control. These nerves allow for swallowing, controlling the tongue, and ensuring that the muscles in the hypopharynx are slightly contracted. Alterations in the signals from these nerves can produce too much relaxation or too much constriction of the airway. Trismus, in which the teeth are clenched closed, can make managing the airway very difficult. Trismus can occur in responsive or unresponsive patients. In an unresponsive patient, it may indicate a seizure is in progress, severe head injury, or cerebral hypoxia. The patient may need to be sedated or paralyzed to relax the clenched teeth and allow you to better control the airway. Of course, this is an advanced level skill. Breathing. As part of your assessment of the patient with a neurologic issue, you need to check the rate and rhythm of breathing. Rhythms can have subtle changes or be dramatically different from normal. Generally, the greater the deviation from normal, the more severely the nervous system is affected. Circulation. Evaluating the peripheral and central pulse pressures. Are they the same? The absence of a peripheral pulse with a central pulse present should cause you to suspect shock. What is the characteristics of the skin? Do you see evidence of gross bleeding? Is the pulse bounding? Remember, shock is rarely caused solely by a neurological problem. If a patient has increased ICP, the vitals may provide evidence of this problem. So, for example, in shock, we'll see increased heart rate, increased respiratory rate, decreased blood pressure, and a narrowed pulse pressure. If we look at increasing ICP, we'll have a decreased heart rate, decreasing respiratory rate, increasing blood pressure, and a widening pulse pressure. So the blood pressure rises, the pulse and respiratory rate falls, and the pulse pressure widens, again due to systolic hypertension and increased ICP. This set of conditions is known as Cushing's reflex, and they are the opposite of what is expected in shock. As ICP rises, blood flow to the brain diminishes. To compensate, the medulla oblongata sends signals to the heart to increase the force of contraction. This causes systolic pressure to rise. If the ICP continues to increase, downward forces on the brainstem begin to damage the medulla's ability to send signals to the body. The diastolic blood pressure falls as the blood vessels relax or dilate, which in turn results in a widening pulse pressure. Finally, this pressure damages the ability to control respiratory and heart rate. Consequently, both decrease. Consider your transport decision. At this point in the examination, you may have a broad decision about whether to load and go or stay and play. Critical patients, those with alterations in their initial assessment or significant MOI and a history of present illness, should be transported urgently to an emergency department. So defer gathering very detailed information about these patients. Instead, focus on stabilizing and maintaining the ABCs. With stable patients, those with normal initial assessments and minor MOI history of present illness, you may have more time to gather detailed information at the scene. You can question family and bystanders to gain valuable insight into your patient's issues. Just a special consideration before moving on to the history. When you're working with a geriatric patient, take their past medical history into account. Patients with a history of dementia will be very complicated to treat. The primary question is, how much change has occurred in the patient's level of consciousness? Do not assume that the patient's baseline level of consciousness is what you would consider normal. Speak to family, friends, or other caregivers to determine the patient's baseline level of consciousness and document that very clearly using active language. Moving on to focus history and physical examinations. Part of your rapid trauma assessment, once the initial assessment is complete, you need to decide how to proceed. Is the patient stable or unstable? Do you suspect a major problem just below the surface? How should you transport this patient? At this point, you have two choices. Complete a rapid assessment using a full head-to-toe approach, or perform a focus history and physical examination. For example, evaluate only the area of the patient report. You should perform a rapid assessment for any patient who has an abnormal initial assessment, has a significant MOI or history of present illness, or who you suspect to have a major problem. Examples would include those who are unconscious, are seizing, or experience a sudden loss of movement of the body. The focus history and physical examination are done on patients who are stable and have limited issues. These people have a completely normal initial assessment and a minor MOI or history of present illness, and you suspect a very local problem. Examples would include patients with headaches or non-traumatic back pain. Avoid using terms that have multiple meanings, such as lethargic, sleepy, obtunded, or out of it. Instead, describe the patient using active language. For example, potentially confusing. Arrive to find a male patient who is out of it. That's confusing. Better, arrive to find a male patient disoriented to place and day. So it's more specific. So another example of a confusing way to explain it. Caring for a 43-year-old obtunded male. Something that would be a lot more specific and better would be caring for a 43-year-old male who is very slow to respond to painful stimuli. Another special consideration is in the pediatric population. Just consider the developmental stage of the child. A 1-year-old should cry when assessed. That is a normal reaction to strangers. Versus a 5-year-old who normally talks freely may be rather tight-lipped with a stranger. It's important to be cautious. If a patient has a headache, stress may not be the cause. Stroke patients can also experience headaches. If you suspect a more complicated problem, perform a rapid assessment to ensure that you give the patient the best possible out-of-hospital care. History. History taking in the present in a patient with a potential neurologic issue should follow the same process followed for any other medical or trauma patient. For example, if weakness is a symptom found in a medical patient with no trauma, use the OPQRST mnemonic to elaborate on the report of general body weakness. The physical examination for this should investigate potential cardiac, neurologic, respiratory, metabolic, or infectious causes. Appropriate tests in serial vital signs such as blood glucose levels, 12-lead ECGs, lung sounds, and temperature will also help you rule out potential causes of weakness. The detailed physical examination examines all of the areas covered within the rapid assessment, but looks at them more closely. The head is the area where you will spend the most time gathering critical information on the functioning of the nervous system. Of course, you want to assess the head for trauma. Deformities, contusions, abrasions, penetrations, burns, tenderness, lacerations, and swelling, so the famous DCAB, BTLS, or CLAPS-D tics, are the common trauma assessment components you should assess on every body area. There are many shades of level of consciousness and many ways to evaluate it. A patient may be interacting appropriately with the environment or not at all. So there may be a continuum that ranges from what would most consider to be normal behavior to no response whatsoever. We can go on the continuum for completely or even hyper-aroused down to all the way to coma, a state in which the patient does not respond to verbal or painful stimuli. So it's important to really see it, our mental status, as a continuum, and a patient may fall anywhere on that continuum, including the extremes. One tool to assist with a consistent evaluation of level of consciousness is the GCS, or the Glasgow Coma Scale. This assessment tool provides a basis to determine a patient's degree of illness or injury. It's used to determine the patient's level of consciousness and evaluate responses to eye-opening, as well as verbal and motor skills. To determine the GCS score, add the three numbers together from each of the subsections of the GCS. So this is something that we all know well, and it's also posted in the Google Classroom. So the top points for each section is 4 for eye-opening, 5 for verbal, and 6 for motor, for a total of 15, and the minimum is 3. So the GCS score can provide information as to what out-of-hospital care should be given and where the patient should be transported. Changes in the patient's mood or tempo of the nervous system should alert you to changes in neurological status. Oxygen levels or blood pressure could be falling, body temperature could be climbing, a psychiatric condition could be escalating, blood glucose levels could be high or too low. Regardless of the underlying cause, your observation of a change should prompt further evaluation to ensure that the appropriate level of out-of-hospital care. Mood or affect is another attribute that provides insight into the patient's condition. Ask the patient how he or she feels. Frustration, anger, or aggression can be caused by low glucose or oxygen levels. Ask the patient how easy it is for him or her to think. Patients who have decreased blood glucose levels or who are taking opioids can experience difficulty concentrating. Lower blood glucose levels in opioids tend to produce sedation of the nervous system. In contrast, patients who are taking cocaine may experience difficulty concentrating due to excitement or mania. Cocaine is a sympathomimetic, which increases nervous system activity, causing thoughts to come very quickly. If the speed of the nervous system activity continues to increase, the patient may hallucinate or become delusional or psychotic. Visual findings. Again, doing your CLAPS-D tics or DCAB BTLS assessment. Look at the symmetry of the face. Is there obvious facial droop? Look at the eyes. Are the eyelids even bilaterally? Do we see ptosis, which is drooping eyelids, which can indicate Bell's palsy or a stroke? Again, you can do the rest of your stroke assessment. Ask the patient to smile. Weakness to one side of the face causes facial droop and slight ptosis. Assess the cranial nerves. They're peripheral nerves that control various portions of the body. Look for the ability to respond, strength of response, and symmetry. Patients with stroke, trigeminal neuralgia, myasthenia gravis, or other neurological conditions may demonstrate abnormal cranial nerve functioning. Diving deeper into speech, listen to the quality of the speech. Is it slurred? Slurring is a classic finding with stroke. Is the speech appropriate? Focus on not only the quality of the words that are spoken, but also the appropriateness of those words. Sometimes speech may be clear, but word choice is incorrect. Assess the patient's object recognition ability. Patients may be able to speak clearly, yet have subtle knowledge deficits. In agnosia, a meaning without, gnosis meaning knowledge, patients will be unable to name common objects because connections between visual interpretation of objects and the words that name them have become damaged. Versus apraxia, a meaning again without, praxia meaning movement, refers to the inability to know how to use a common object. Remember back to our child Justin riding his bike. To test for these signs, simply show the patient your pen, scissors, or set of keys. Ask the patient to name the object. If the patient responds correctly, hand the object to the patient and ask him or her to demonstrate the object's use. The patient should know how to write with a pen, cut with scissors, and turn a lock with the keys. Patients may have one of these signs without the other. One is not more severe finding than the other. They simply indicate that some degree of misfiring of neurons is occurring between the occipital lobe and the temporal lobe in agnosia, or between the temporal lobe and the frontal lobe in apraxia. Language can be affected by injury or disease. In aphasia, speech is affected. There are three main forms of aphasia. The first one is receptive aphasia, where the patient cannot understand or receive speech but is able to speak clearly. This form of aphasia indicates damage to the temporal lobe. Ask the patient questions to which you both know the answer. For example, who is Prime Minister? What month is it? Do not ask yes or no questions. If the patient speaks clearly but gives incorrect answers, he or she may have receptive aphasia. In expressive aphasia, the patient cannot speak or express themselves clearly but is able to understand speech. This form of aphasia indicates damage to the frontal lobe, which controls the motor portion of speech. Ask the patient to raise an arm. If the patient responds correctly, he or she can understand you. Ask the patient for his or her name. If the patient cannot respond, or if responses are slurred, the patient has expressive aphasia. In the case of global aphasia, this form of aphasia is a combination of both expressive and receptive aphasia. Now, in this setting, the patient will not follow commands and cannot answer your questions. Nevertheless, patients with global aphasia can often think clearly. They have needs, anxieties, and discomforts, but no way to express them. This can be incredibly frightening for patients who cannot understand anything that you're saying and cannot speak to you. Be sensitive to this state. Move slowly and purposely. Use therapeutic touch and good eye contact to reassure the patient. Pupils. Pupillary shape can be changed by trauma, glaucoma, or increased ICP. Cocaine, methamphetamines, and hallucinogens tend to cause dilation of the pupils. Depressants usually lead to constriction of the pupils. Equality of pupils is an important observation. Anisocoria, which is unequal pupils greater than 1 millimeter difference, can be a sign of increased ICP. Many people have a slight inequality in pupillary size. Anything greater than 1 millimeter difference is worth noting. However, any pressure increases within the skull, the brainstem can be squeezed. This squeezing can interrupt signals to one pupil, resulting in the dramatically different pupil size. It's extremely important to note that in the absence of other symptoms, anisocoria could actually be a completely normal finding. Finally, determine whether the eyes are twitching. So this would be nystagmus, which is the involuntary rhythmic movement of the eyes. It can be caused by seizures, vertigo, and MS. Looking at the movement of the body. Observe how the patient moves. Does the body move equally on both sides? Patients with strokes may have weakness, or what we call hemiparesis, or paralysis, what we call hemiplegia, of one side of the body. Sometimes you may discover patients with weakness on one side of their body, but facial droop on the other side. This condition may be caused by decussation, in which nerves cross as they leave the cerebral cortex, move through the brainstem, and arrive at the spinal cord. Nerves that decussate start on the one side of the brain and then cross to control the opposite side of the brain. Some nerves do not decussate. Facial nerves, for example. The left side of the brain controls the right side of the body, but the left side of the face A left cerebral stroke would therefore result in right side arm and leg weakness, but left side facial droop. Examining the function of the cerebellum can also allow you to gather information about potential damage to the brain. Have the patient close his or her eyes and hold out their arms in front of the body at the same level. With the eyes closed, the patient's only way to tell where the arms are located is from the sensations being processed by the cerebellum. This is called pronator drift test. If the patient has experienced a stroke, one of the arms may drift away from the other. Have the patient walk for several steps unless some medical reason rules the activity out. Assessing gait, so walking patterns, is another way to test the activity of the cerebellum. Walking is really a controlled fall. As your center of gravity moves forward, you must move a leg forward to catch oneself. Once you learn how to walk, your cerebellum controls these mechanics, so you can focus on where you want to walk, not how to walk. Damage to the cerebellum may be manifested as erratic walking, stumbling, or even losing the ability to walk. Several medical conditions cause alterations in the patient's gait. Ataxia is the term used to describe changes in a person's ability to perform coordinated motions like walking. Patients with Parkinson's disease exhibit a classic gait in which they place their feet very close together and shuffle. Their stride is short and they have a great difficulty changing direction. Such a patient will shuffle walk in a straight line, and when asked to turn, will take very small steps until the turn is complete. With this kind of bradykinesia, routine motions may slow dramatically. In contrast, patients with cerebral palsy may walk with a scissor gait. In the spastic form of this disease, the person will point the toes inwardly, have a stiff gait, and nearly touch the knees together while walking. In addition to the patient's gait, you should assess the posture. Have the patient stand straight. Place one hand on the patient's chest and the other hand behind the back to catch the patient if he or she cannot do so, and then push on the chest. Normally, as you push backwards, the patient will compensate quickly and take a step forward to prevent falling. In Parkinson's disease, the patient's posture is so rigid that he or she cannot compensate quickly enough and will fall over. So definitely don't be doing that in the out-of-hospital environment. Bizarre movements may indicate a disruption within the nervous system. Myoclonus is a type of involuntary contraction of the muscles that is rapid and jerky in nature. Most people have experienced myoclonic jerks at some point. Have you ever seen a seated person who is very tired? As the person gets closer to falling asleep, the head will begin to sag. Often the person will involuntarily jerk the head upward, which is a myoclonic jerk, and wake up. I'm sure everybody has experienced this. Another form of bizarre movement is dystonia, in which a part of the body contracts and remains contracted. A foot cramp where the great toe extends while the other toes curl under is an example of common dystonia. Alternatively, the face may become extremely distorted as one side contracts. The head can twist to one side. An arm or leg can become frozen in a contracted position. Dystonia can be caused by brain injuries or medication reactions. When you're watching the patient, does he or she move smoothly? This kind of motion requires proper functioning of the frontal lobe, cerebellum, brainstem, spinal cord, and peripheral nerves. When they are functioning correctly, muscle groups will alternatively contract and relax, allowing the body to move smoothly. Patients with Parkinson's disease experience rigidity in which this fine balance is upset, so they move in fits and spurts. Tremors are another potential alteration in smooth motion. These fine oscillations or oscillating back and forth movements are usually found in the hands and head. Rest tremors occur with the patient at rest and not in motion. They are common in Parkinson's disease. So you'll see they'll have what we call a pill rolling tremor. Intention tremors occur when the patient tries to reach out and grab an object. The tremors may increase as the patient gets closer to the object to be grabbed. Intention tremors are common in MS. Postural tremors occur when a body part is required to maintain the same position for a long amount of time. Most people have experienced this type of tremor when they were working hard for a long time. As they tire, their work body parts begin to shake. A postural tremor can also occur when a person is standing and the head oscillates back and forth. Patients with Parkinson's disease also experience these tremors. Seizures may appear very similar to tremors. Generally, tremors are fine movements, while seizures are larger, less focused types of movement. There are two types of movements that patients can perform while seizing. The first is tonic activity, which is a very rigid, contracted body posture. The arms, legs, neck, and back can contract so tightly that the body part will shake slightly from the intensity of the contraction. The other is the clonic activity, which is a rhythmic contraction and relaxation of movements of any body part. Arms and legs may flail, teeth may clench, the head may bob, and the torso may move wildly. Looking at sensation, many neurologic conditions can alter the ability to feel pain, temperature, pressure, or light touch. A sensation of numbness or tingling called paresthesia. If the patient can feel nothing within a body part, the condition is called anesthesia. So we'll be doing what we call our 6Ps NNA when we're assessing any and all extremities. The blood glucose level, and of course, as we know, glucose is the fuel that runs the brain. The brain uses glucose faster than any other part of the body, but it has no means to store glucose. For this reason, all patients with change in level of consciousness should have their blood glucose level checked. A normal blood glucose reading, as you know, is between 4 to 7 millimoles per liter. As glucose levels fall below 4, the level of consciousness begins to decrease. Level of consciousness can also be affected by high glucose levels, although a significant increase is required before level of consciousness is altered. Glucose levels below 0.6 millimoles per liter are incompatible with brain function and typically lethal. Generally, if levels are below 2, confusion or unconsciousness will occur. Blood glucose monitoring is standard out-of-hospital care for patients with altered level of consciousness. So one example where you might see somebody with altered level of consciousness in hyperglycemia, they'll be in a state of what we call DKA or diabetic ketoacidosis. The chest. So again, using our CLAPS-D-TICS or DCAP-BTLS for the assessment of chest, look for symmetry in its shape. Does the chest rise and fall equally? If not, it's called paradoxical chest movement. Apply the cardiac monitor and evaluate the ECG. Many cardiac dysrhythmias can cause neurologic disorders by decreasing the blood flow to the brain. Perform a 12-lead ECG in all patients with a sudden loss of consciousness. How much effort must the patient make to breathe? Do you observe any degree of respiratory distress? Listen to the lung sounds. Evaluate for presence of adventitious sounds and equality of sounds. Determine the pulse oximetry reading. Remember that normal readings are 95 to 100%, and that this number is affected by the amount of hemoglobin within the body and the presence of carbon monoxide. Abdomen, DCAP BTLS again. Do you note any masses? Are there any pulsations within the abdomen? Does the patient have any issues related to the abdomen? Signs of nausea and vomiting are common with some neurologic conditions such as headaches or increased ICP. DCAP BTLS for the pelvis. Is the pelvis, are you able to stress the pelvis? If the patient's able to walk without assistance, the pelvis should, obviously, you can consider the pelvis stable. Does the patient have any incontinence? So urinary or fecal incontinence is common finding with seizures or syncope. And incontinence also serves as a relatively objective marker for the severity of unconsciousness. When we sleep, we are not incontinent. Thus, if continence is present, the level of consciousness has decreased below that of sleep. For the extremities, CLAPS-D-TICS, DCAP-BTLS again. Do you see any signs of edema? Look for venipuncture marks and note whether these marks are at various stages of healing, because these marks can actually be an indication of illegal drug use. Through your ongoing assessment, the ongoing assessment is intended to monitor patients for changes, talk with them, ask them how they're feeling, ask about their children, ask if they caught the game last night. Casual conversation will allow you to closely monitor brain functions. It also communicates a caring environment. And if the patient is nonverbal, keep a close eye on their respiratory patterns and eye and body movements, and monitor for seizure activity. Routine monitoring should include heart rate, ECG, blood pressure, respiratory rate pattern, pulse oximetry. Repeat the glucose. If the level was low and sugar was given to the patient, or another medication, for example, glucagon. Continue oxygenation and ventilation support. And if the patient's condition undergoes a sudden dramatic change, repeat the rapid assessment and detailed physical examination as if they were a new patient. Redo your ABCs. This will give you a chance to modify your out-of-hospital care to manage any new changes. Continuing on with our case, so you place your patient on the stretcher. You and your ACP partner administer normal saline at a to keep vein open rate, draw blood, and perform an ECG. You also complete fibrinolytic screen while en route to the hospital because you are working in an advanced system. So the patient's medical history includes AFib, as he takes aspirin, diltiazem or cardizem, warfarin, and metformin. The patient has no known drug allergies, has no recent history of illness, and has been compliant with his medications. So would you choose to place this patient in a manual inline spinal precautions? So would you immobilize this patient? What places this patient at greater risk for a cerebrovascular accident? General management. This management guideline should be followed with all patients who experience a change in level of consciousness. The focus of out-of-hospital care for neurologic patients is directed at ensuring that the body has adequate internal environment to allow for optimal brain function. The three major elements that the brain needs to function are oxygen, glucose, and a normal temperature. The general management techniques that we'll go over the next slides serve as foundations on which additional out-of-hospital care for specific neurological conditions is built. And these general steps will be discussed further on in more detail or in class. So always provide for standard precautions and scene safety. Evaluate the patient's airway and effectiveness of breathing. If necessary, secure the airway and provide ventilatory support to make sure oxygen saturations remain within normal limits or within normal limits according to your protocol. Of course, one thing that's very important to also understand is sometimes a patient may present with some abnormal findings, for example, abnormal breathing too rapidly. It's very important to understand what is going on with your patient because they may be in a compensatory state and you don't want to go fight that compensation. So taking your full set of vital signs, as we just talked about before, it's extremely important. Look for your hallmark signs of increasing ICP. Getting a really detailed, focused history of the patient's, not only history of present illness, but their medications, their allergies, their past medical history. And then, of course, if it's a chronic neurological condition, just provide emotional support for the patient and their family because it can be very difficult and slow disease process.